Now it's my pleasure to ask Chitra to take over and present her pearls.
Thank you very much, Dr. Ramamurthy, for this wonderful opportunity to present in this August audience. And my tips are something which maybe all of us could connect it, very simple and very much day-to-day pearls. Like, how are you going to hit target emmetropia? Now, all of us are wanting every surgery of ours to be hitting target emmetropia. And for this, I have given the choice of using the Barrett's suit with all the formulas. That it's essentially a thick lens formula, and it takes care of the regular universal or the toric, or it is used for refractive surgery or combines in refractive with toric, or as a enhancement procedure. But whether it's Barrett or anything, it has to be a 4th generation formula where it's not only axial length and K value, but also anterior chamber depth and many more details which are coming in. Before we take any patient when he comes for counseling, first thing we do is put them onto the Barrett toric calculator and find out whether the person has some amount of cylinder or astigmatism. And if there is, then we take our direction and tell him that you could consider a monofocal, but since you have an astigmatism and you want total independence for distant vision and a hit emmetropia, then why don't you go for a toric calculator? Now, why am I insisting on astigmatism correction is, even more than 0.5 diopter astigmatism, the image quality declines if it is not corrected. So if you want that precision in image for your patients, you need to take care of that. And it becomes even more important in premium multifocal IOL that even if the astigmatism is just 0.75 diopters, it has to be corrected. And how you would go about it, now again, if it is against the rule astigmatism, even 0.75 could be treated with a toric IOL. The other important thing for hitting emmetropia is getting a good K value, because there are a lot of variations in the gadgets and also the ocular surface. In fact, if you look at this slide, the patient had 0.5 diopter astigmatism in the right eye and +2 in the other eye on doing a keratometry. But when we saw him on the slit lamp, there was so much of pigment epithelial erosion and dry eye signs. So after treating the dry eye, when we remeasured the astigmatism, it was only 0.2 in both eyes. So if we had not clinched this dry eye issue about that patient, our biometry, keratometry, everything would be bizarre, and where would be hit emmetropia? Again, in this patient, he has a +1 diopter in 1.6 in the right eye and 0.3 in the other eye. If you look carefully at the Myers, it has a fishtail appearance, and there is some artifact there. So all of this would again has to guide you. There's something wrong in the ocular surface, treat the ocular surface, and then the astigmatism is reduced. So then, we also know that optical biometry is top-notch for axial length measurement. But again, immersion is great, but there's nothing wrong about immersion. But when you're doing immersion, this patient has 22.4 axial length in the right eye and 21 in the left eye. Why is it smaller in the left eye? But then if you look carefully, you realize this particular patient incidentally had a macular tractional detachment with subhyaloid hemorrhage, which is why he had a false short axial length. And if you had not checked on this, you would have put a +7 diopter, a different IOE power in that eye. So then, again, what is it finally for hitting emmetropia? Treat the cylinder. Use the 4th generation formula or better. Please measure both eyes. If the axial length difference between the two eyes is more than 0.3, repeat your measurements. If the K value between two eyes is more than 1 diopter, repeat measurements. The IOL power difference between the two eyes is more than 1 diopter, repeat measurements. In fact, you should measure both eyes. Even if the other eye patient comes with a pseudophakia in one eye, please measure that eye, because variations in the axial length and the anterior chamber depth, K value, will tell you whether the eye which you're going to operate, whether those measurements are correlating or are you on the right track. So we go on to my tip 2. What would be your choice of IOL after laser vision correction? Is there a role for diffractive IOL? Now that's a very pertinent question for post-LASIK patients. Now this was a spotlight study in AAO which looked at a patient who had a good topography. What was the popular demand of the audience? There were 55% who wanted monofocal mini monovision, and 27% wanted EDOF, and 9% wanted multifocal. Now, let's be logical. If the patient has, during LASIK in his late 30s or early 40s, comes to you for laser correction, you could do a mini monovision, monofocal monovision, and he will be very happy for that in his premium cataract surgery also. If he's a high myope, it doesn't make sense to put a multifocal. You could do a monofocal, or you could put an EDOF IOL, because his contrast sensitivity is already hit by the high myopic ablation on the cornea. If it is a hyperope patient, you could put an EDOF, you could put a monofocal, but you could also put a multifocal if it is not a very high hyperope, because the central cornea is not very much affected in a hyperopic ablation. So we also know that all these lenses of aspheric, enhanced monofocal, EDOF, everything does very well in an emmetropic eye. But how do they do in a post-LASIK eye? And what would be the IOL formula which you would use? For that, again, there was this spotlight on asking audience questions, and it was found that many people felt that the ASCRS calculator was, the Barrett's True-K was the best, followed by ASCRS. So, and then came Haig's L. So this is how each person had experienced. So we tried this on our patient here, and if you look carefully, maybe the lettering is small, but what in this came true was the patient needed toric in both eyes, but he did equally well with the Haig's L measurement and the Barrett True-K measurement. The important consideration for a multifocal IOL patient is when your patient says he's had LASIK, but he tells you that he was very happy with the quality of vision he gained after refractive surgery. If you see his ablation is well centered with no irregular astigmatism, if he tells you he had no night vision problem, you see he has a good ocular surface and is a highly motivated patient, go for multifocal IOL in a post-LASIK patient. Look at the topography. Look whether it was a myopic ablation or a hyperopic ablation. Look at that 3 millimeters. Is it a decentered ablation? Then no multifocal. Is it the residual astigmatism? Is it irregular? Look at the ablation pattern. Look at the ocular surface. Look at the eye trace, whether the corneal aberrations are more or the internal aberrations are more. And is there irregular astigmatism? If two IOL master and lens star are differing, if the difference in astigmatic meridian between the two biometers are off, then go back and repeat your measurements. And then, if you're using Barrett True-K, you may not have the best of keratometers, you can still use the predicted K value of the Barrett or the measured K values. You can go into that particular format and you could calculate what is going to be the astigmatism. You could do it on the laser cataract platform or the best surgery possible, and this patient will do very well. But you need to tell this patient that you may have a residual, you may need enhancement. The last tip is a small tip. This is phaco following lens touch. Now this kind of cataract which you see immediately or shortly after surgery is seen more in a gas tamponade. So you need to be very careful about doing hydro in these eyes. The rapid progression of cataract does not happen. It takes 6 months to 1 year, 1.5 years, unless there has been a lens touch. If you do a uveum, you will see the posterior capsular dehiscence and the little lens matter. You will see little loss of compactness of the nucleus. And then you also, what you should do is, if you feel there's lens touch, wait for a period of 6 weeks, let that area of opening fibrose, and then you could go ahead and do the surgery. And the last bit, when you do surgery after 4 to 6 weeks, expect a deep anterior chamber. Remember, there's no vitreous support, and you have to keep your parameters low. You need a structured wound. You need to keep in mind there could be a retrolenticular block. So you need to be conscious of all of it. And sometimes you could even have a PC plaque, and you need to be able to peel it and take it out. However, this case was very uneventful and it got done. I have one more pearl. Should I leave it? Huh?
We can stop here. I think very pertinent points that were made, and perhaps to me the most important factor is the formula that we use for biometry. We swear by the Barrett suite of formula for all situations, and our go-to formula is not Barrett Universal 2 but Barrett Toric Calculator. Because I'm often asked, what's your limit as far as introducing toric lenses is concerned, whether it's 0.6, 0.7, 1, etc. Please remember, against the rule astigmatism and with the rule astigmatism have completely different connotations. So we put all these patients on Barrett Toric Calculator and let the formula tell us whether the patient needs a toric monofocal, toric lens. Then subsequently, the counseling happens as to whether it has to be toric, monofocal, multifocal, etc. So rather than just going by the magnitude of the astigmatism, take on also the amount of the axis of the astigmatism which is incorporated in the formula. As regards usage of premium lenses in a post-refractive surgery scenario, I would like the three of you to comment just briefly.
Yeah, I think regarding the post-refractive, she's covered it pretty well. I have only one thing to add. If a person has had a press-beyond done, then you don't need to do any of these things because the cornea stands, it still has the abrasion profile, etc. that has been done. So if you have had a press-beyond, then the cataract surgery, you would want to do a typical just a monofocal or maybe a monofocal plus. You won't want to look at EDOFs, or you don't have to look at multifocals. But for me, a preference would be to give a mini monovision post LASIK. The lens power calculations are pretty accurate that you have on the Hagizel and the Barrett, and that you get on the IOL Master 700 now. I think almost all the new Lenstar also has the post LASIK, and the Interion also has it. So that's almost a standard of care. The problem that typically comes is to get a good power post RK. Because that whatever you may do, it's a slight problem. I do put torics in post RK, but you have to do a true net K and then work on that. So that's all that I will wish to say on refractive surgery.
Partha?
Yes, so just to add about the refractive surgery part. So I, for the last nearly 15 years, I've been following the best of calculations, and here, of course, the Barrett is the best that we calculate. But the last thing that we do is a cross-check with our senior-most optometrist to do a phakic retinoscopy on the table, so that to avoid any surprises. And it has worked very, very well. We always try to keep post-LASIK myopia, somebody who has got LASIK for myopia, a little on the, to err a little on the myopic side, and till date, no surprises after doing this.
I think you're the only one I know of with a large volume who does this. What is the multiplication factor that you apply for the refraction?
Approximately 0.8.
0.8. Okay. Yes, Dr. Abhay?
No, I just wanted to say some of these things that you've been told, but post-RK, I think the regularity of astigmatism is very important. So many of these with little astigmatism, make sure it's regular. Do not put it in irregular. And we use all these eyes, post-treated corneas or otherwise, Barrett, True K, because as you very correctly emphasize, you'll be surprised, because if it is with the rule or against the rule, and there the formula will show this is T2, it's half a diopter of thing, and that's worth doing it, particularly if you're doing a multifocal, trifocal lenses and so on. So that you must test whether does it need toric with the formula, not by your assessment or judgment.
Also in a RK, if the optic zone is very small and there are too many incisions on the cornea, there is irregular astigmatism, and these patients will do good with maybe enhanced monofocal or maybe a EDOF if the irregularity is not much.
No,
but definitely not a multifocal.
More than concern for multifocals or enhanced monofocal is whether to put a toric lens in or not. If the patient was having good visual correction with glasses, did not need a semi-soft or a rose scale lens for the refractive correction, then he or she is a good candidate for a toric intraocular lens also. But if it was mainly higher order aberrations, irregular cornea, where he or she required a rose scale lens or a miniscleral lens for visual rehabilitation, then obviously a toric ICL or a toric intraocular